I'll appreciate it. I will continue. It is the end of the day for you, but for me, and here in California, if you look east in the morning, you're going to see the sun rising, and it's about 6:30 in the morning. This is the view of the mountains. It is right from my office. We work with the doors open. The weather is very pleasant at this time of the year. As you drive maybe down the same road, Cedar, and leave town about 2-3 miles out, you are going to be looking at these rolling fields. And straight ahead, you see this blanket of snow. We had a lot of heavy rains and a lot of precipitation on the Sierras. So they are beautifully covered with these views right now. It's very similar to being back in Chandigarh. And if those of you have been there on a winter day after it snowed on Kasoli, the view is the same. So having told you about where I am, what I'm doing, I'll move on to the problem at hand. I thank Professor Mendiratha again for this very kind introduction. But our goal is to make your life easier and make you good readers of EEG. I assure you, if you stay with this course, you will become very proficient, very comfortable with it. For those of you who are just starting out, all these waves just look like, where do we start? What do we look at? And what is an artifact and what is not? Just remove the background, please. Just remove
Good evening, Dr. Suri. Sorry, I was a bit late for 2 minutes.
Good evening, Dr. Sangeeta. How's everything in Bombay?
There is a lot of noise. May I request, please, there's a lot of noise on the background, host to look after. Please see that the speaker is not interrupted, disturbed. Apologies, Dr. Madhav, apologies.
Okay, we'll continue. If you'll remove the background in the meantime, that would be great. But continuing with how we're going to approach EEG, we will be looking at a single page of EEG. Don't want you to move to the next page. Stick with the one page and try to get as much information out of that one page, because you can read almost 80 to 90% of the EEG within that one page. So select one epoch right in the beginning and let's start analyzing it. I think you can see my mouse moving, and if not, let me know. This is the way I'm going to point out to you. On the left-hand side are the montages. I'm going to keep it simple. We will use double banana, longitudinal bipolar. This is high rising left, high rising on the right, low lying left, and low lying on the right chains. Okay, I'm going to avoid any other montage at this time, except when we get down to a cross-referencing or making sure that the discharge is coming from a given location. In the bottom right-hand side for orientation, you'll find all the parameters of the date. This recording 2010 at my lab, in the office, the time, and you will see the sensitivity. The speed is already indicated. This is your standard speed. Now, oops, sorry. After you've looked at all of these basic parameters and you've identified the EKG channel, you ensured that, yes, you have what looks like a good fidelity to the recording. Then the next step is to go ahead and start looking for anything that looks like non-biologic, anything that looks like this couldn't be coming from the brain. So example, if you look at the arrow, you'll see that there is a positivity at F73 because the adjacent channels, the deflection is moving away from F73. Positivities are very rare to find and therefore likely to be a non-biologic finding. Interestingly, it is right over the area of interest. So, but keep your eye on these parts and exclude the artifacts first. Okay. Similarly, here's another example of the same montage, left over right, where you are looking at a discharge coming from the left temporal area. It's very fast. It has a very narrow ascent and descent. And this is nothing but a motor unit from the left masseter muscle. It is EMG. You do not want to be misled by these kind of findings. So the first thing we did when we looked at EEG at the lab in Einstein was, among the fellows, we would have this discussion saying, is it real or is it Memorex? Memorex was an ad by a tape company that recorded Ella Fitzgerald, a famous singer. They claimed that their recording was so true and so pure that playing back the recording could shatter a wine glass. So your first question should always be identify the artifacts and eliminate the artifacts in your mind. As you start looking at this page, you eliminate those artifacts. Remember, reading an EEG or inspecting a page of waveforms is just like doing a neurological exam. For those of you who are neurologists listening in, just as you have the patient before you and you try to determine the anatomical distribution, same way, you're going to spatially reconstruct the generators that are making those waveforms appear on that page. Just like you have, let's say, a left hemiparesis, and you try to formulate with the exam, the history, a clinical diagnosis, where is the lesion? Similarly, you will put together all these findings and write a clinical summary of this to tell the referring physician what is the clinical significance of the findings that you observed. Okay, so having done the artifact identification, next you look at the background. Now, I've been following your WhatsApp group on EEG, and several of you may be listening in, have asked this question about the background. To try to assess that, we will put this rectangle over the EEG in an area which is not as disturbed as what you see on the right-hand side of the field and the left-hand side of this epoch. In that section, your eyes, your parietal lobe will be drawn in. This is what we call a magnifying glass. Look at the waveforms in this area. You look for whether there is a fronto-occipital gradient. This will be the front of the head. This will be the back of the head. You see a difference. There's more fast activity in the front of the head. There is an alpha rhythm at the back of the head. That tells you that this is an organized record. Next, you go and look at the general background. So you bring your magnifier down, eliminate the front and the back, and look in the middle portion. That is your general background. And you'll be reporting on all these areas in the report. And lastly, the posterior background is this back of the head. So when you talk about posterior background slowing, which we'll come to, then the rhythm in this part of the brain is slower as compared to the general background or in the front of the head. Now, when you're starting out reading, in the first month of your reading, you will still, have trouble with what am I looking for? Where is the background? And show it to me. So I have used this analogy. It is similar to laying out a table. When you go to eat, whether you're at a restaurant, a friend's house, or home, when the table is laid out, you immediately know where to reach for the spoon, the knife, and the fork, where the glass is going to be placed. So there is a particular background for adults, and there is a particular background for children. This part of the lecture will be taken over by Arya, who is my golden child. She's golden because she lives between the Golden Gate Bridge and the Golden Gate Park. And she offered to, give me all of her daily usage items. And with her, it's Arya get, Arya do it, which is her way of wanting to participate. So this is how she would lay it out. Remember, pediatric backgrounds are slightly different from adult backgrounds. Children have more slowing in the back of the head. So you will see more posterior slow waves in the back of the head. You will see ORDA, that's occipital intermittent rhythmic delta, and it is abnormal except in one condition. And we'll get to that in just a minute. Anybody knows the answer? Put it in the chat box. All right, coming back to our page, the epoch. Having looked at the background, you've identified the artifacts. Now you look at the asymmetries between the two sides, and you look and see if there are voltage asymmetries. There is one caveat in this. Remember, you are in a longitudinal bipolar record. So you are basically looking at the difference between two channels. To properly assess the voltage, you should switch to a referential montage, possibly an ear montage. And if the patient's not asleep, go to a CZ montage. All right, now you have looked at all these various factors. Now you bring your eyes to the obvious abnormality, and what you see is a beautiful initial negativity, then a positivity, then an aftercoming slow wave for about half a second, spike in wave. Localization, left temporal. Field, negativity at F73. Therefore, yeah, this is biologic, it's real, okay? If you've identified it in the bipolar montage, cross-check, make sure that that's true, and you will then switch to a referential montage for a temporal abnormality. A good reference would be CZ, especially if the patient is awake. You can also look at it in the average. Just keep in mind that average requires a little more brain work because sometimes it's contaminated. And then you have to factor in the part that is contaminated into your field determination. All right, to summarize, you will check the montages, identify the artifacts, look at the organization, the entire record. The organization is like, a chessboard. Your pawns are in front, your Wazir and your Ghoda and your Rook all are in the back, okay? So you want to see there is a fronto-occipital gradient. In children, very important. This was described by Fernando Torres. You can Google this, his paper. And at the Mayo Clinic, he brought out this idea of what's in the front, what's in the back of the head. We always look at this. Now it is second nature to us. Then you look at the general background, assess the posterior background, the asymmetries, check what has been written on the sheet that you get. I suppose you will all get a sheet from the technologist. Technologists, I hope you are writing on the sheet, what is the head position of the patient, especially a child? Is there a scalp swelling? If this is a child with an IV extravasation, then there's going to be a asymmetry created by the fluid that is sitting on one side of the head. If there's been a craniotomy, then you're going to get a breech rhythm. There's going to be a lack of the attenuator. The skull is an attenuator and decreases the amount of voltage of the surface electrodes. So please look at the notes. The things that we are allowed to look at are age in neonates, especially the gestational age before you interpret, and if there are any abnormalities such as a head swelling or a hematoma before you interpret the record. We do not look for anything else. Medications can also be looked at, but they give you a clue sometimes as to what you're dealing with. Therefore, we try to avoid that. If you see excess fast activity or beta, then you can go back and ask the question, is this patient on barbiturates and benzodiazepines? Then draw the correlation. Okay, having looked at this background on which we are going to find the abnormality, now go to the abnormality. This could be a left temporal spike or a 3 Hz generalized spike wave. You have to train yourself. It's literally a yoga. You have to train yourself to stop bringing the eye to the abnormality. First, get your background sorted out. Then, when you identify the waveform, you try to draw its field because you've examined that waveform in different montages. You check that, and then you draw the isopotential lines, etc., to see how far does this discharge last. When you are writing your report, pay attention to the following things. I've drawn this roughly to make your brain sort of focus on what should be in the report. Instead of calling this a spike, I say there is a discharge which has a initial negativity. Then this is a longitudinal bipolar. We are still in the same montage. So initial negativity, then an aftercoming slow wave. The entire discharge lasts for about 0.25 seconds. Then you describe the voltage of the spike, the duration of the spike. So I would say, let's, for example, 200 microvolts and the duration 150 milliseconds. Then the aftercoming slow wave, I'll describe that again as, let's say, 150 microvolts and duration 150 milliseconds, so as to create a visual image on paper in words, so that when the patient appears 1 year later in the emergency room, another EEG is done, you just have the paper report in front of you. You will recreate in your mind what you saw on that day. That is the idea of writing this report. Okay. These are templates of reports that are easily available. No need to write and draw. I will be happy to share them with you. And they're in Word format. They also have this macro. You see that little star? The macro in Word has been mapped to F2. And those of you who know this program well, better than me, you just press the F2 button and it will jump from field to field. And you can start inserting your findings in each one, which makes it a lot faster. So I'll be happy to give these to you. The way I write the report is as follows. In the beginning part, up to here, is all of the identifying information and the conditions in which we are recording. In the conditions in which we're recording, you will typically say, let's say it's an 18-channel recording, 1 channel is EKG, that you're using 70 channels for the scalp. Your electrode placement is typically 1020 international, and that your filters are starting with a low frequency of 1 hertz. In older machines, this is time constant of 0.3, and the high frequency is 70 hertz. So remove all the other filters. We'll come to that again. The notch filter should also be out. Then you comment on these different sections. The reason for dividing these sections is, A, it forces you to look at it. It forces you to make a comment on these things. And then you know what your base is before you go to describe the abnormality. For example, in a Lennox-Gastaut patient, you need to know that the record is disorganized. If you say record is high voltage, it's chaotic, you know immediately before you go to the next line, this is going to be hypsarrhythmia. Okay. So organization is the first line, symmetry and continuity is the second. The continuity just refers to whether in every second you are seeing the same waveforms appearing again and again. If it flattens out, if there is a generalized attenuation, you immediately know that, for example, in a non-convulsive status epilepticus from the ICU with a discontinuous background, that, boy, this brain has been beaten up. This brain is now dysfunctional and tired and just cannot generate even the basic rhythms. So that first line tells you a lot. Then you go to your background and start describing it. I hope you can see it, but I'll read it out to you. What your posterior rhythm is, 8 hertz, 9 hertz and upwards. Then you describe the modulation. Modulation refers to how the waves will go up and down. There's going to be the alpha rhythm, and then there's a sinusoidal wave, which you see on top of that, riding on. It's very prominent in young patients. So modulation, again, tells you, it's a good brain, it's organized, it's a young brain. Then you go to the general background, and in that, you will describe typically, if the posterior rhythm is say 9 hertz, typically, then you will see a rhythm of 7 to 8 hertz. It shouldn't be much slower. If it's below that, you're likely to be dealing with generalized slowing. And then you look at the front of the brain. Remember, we're going in from posterior to center and then to the front of the head in order. The front of the head is what are the faster frequencies that you see, and which will typically be beta, and you comment on that. Then you comment on drowsiness, in which you say the posterior rhythm has decreased, the voltage faster activity is increased, and this is where you would be seeing the temporal spikes likely to show up. Again, sleep is very important. We will discuss this also a little further. There's a question asked about how do you differentiate sleep activity from spike activity. We'll address that. But typically, we only record this first 2 stages, drowsiness stage 1 and stage 2 sleep with vertex waves and spindle activity. In children, be sure to comment on if the spindle activity is synchronous and symmetric, which it should be by 6 months of age, and what the posterior rhythm is when it has reached a normal rhythm. That will give you a very good idea about whether the record is normal or slow. We also use another term in children of distorted sleep. I don't want to get too far into it, but basically is when you're recording children who are very young, infants, who are sometimes sedated, you get mostly sleep, and in the end of the recording, the technologist will wake up the child and you get a portion awake. So since most of the recording is asleep, and if it is slow, we call it distorted sleep. So if you see that, basic meaning the same, the record is slow. The rest of it is the activation procedures, hyperventilation, photic stimulation. There should be a comment on heart rate. Very important, because you know that the heart rate is driven by seizures, and you can have abnormalities in the heart rate during a seizure or after it. In fact, if you do VNS, your auto stimulation mode, which is the second parameter that you change, is driven by the heart rate. So you know there is a close link between heart rate and the EEG. Likewise, if the heart rate slows down, the Stokes atom, you're going to see a change in the EEG. And that's very important in syncope patients. Then, because we do a lot of long-term recording, and we do event recording in ambulatory EEG in the patient's home, we have a section on push button detections. So for those of you who will join us at the Neurology Education Center, we will be introducing the ambulatory EEG recording shortly. And we'll be using a lot of this. It's just a button that the patient presses. And if he feels he had his typical aura, typical event, it was maybe a bad smell, an epigastric feeling, an episode with dizziness, and so on, then he presses the button and he writes in the chart. When we give them a diary in which they record the time and the date, and then you can go back and make the clinical correlation. During this section, we also comment on those clinical events, verbal events, and anything else related to what we think may be event analysis. Next, we use a program for detecting spikes called Persist. I don't like it very much, but you will see it in the recordings. So there is a comment box for this. You can eliminate it because I don't think it is of that much use, as it is at least the version that I have, which was quite expensive and much older. There are newer versions available now. Then we come to the most important part, which is the classification. So the classification, I will jump to in the next page and show you what that means. But it is basically, you are trying to summarize everything you have seen in 1 or 2 lines for the reader. You have to boil it down. It gets back to, residency when we worked with Dr. Raffins and Spiro. They would say, give me the 30-second skinny. That is, in 30 seconds, you have to say everything about the case and forget the rest. If you can't summarize in 30 seconds, you don't know your case. So you have to go back and boil it down. Then in the impression, you expand on the classification and you tell the referring doctor what you thought, that this was a slow record, that there was an area in the left temporal which you thought was a potentially epileptogenic area. If it is interictal abnormality, make sure you say it's potentially epileptogenic. It is epileptic if you record an actual seizure. We'll get to the difference in a minute. Big difference. If it is epileptic, then it compels the referring doctor to start taking action and increasing medications or adding medications or whatever. If it is interictal, it helps with the diagnosis. There is no rush to increase medication, admit the patient, and so on. So your words have a lot of power. What are the words that you can use to make this communication? Here is a very simplified classification scheme. You've used this for 30 years. It worked me well. So I'm going to share it with you. It may not be exactly the same as what you read in the various classification schemes, but everything that's in the scheme is in this. Means in some way or the other, those abnormalities they are now describing as birds are described already in this scheme. This is what we use when we read records with the fellows. We had exchange between each other, and Dr. Goldens and Moshe were reading with us. Okay, so in the top, this is the highest in the food chain, okay, are the interictal epileptiform activities, or those closely related to an epileptic tendency. In the middle, I've also included some common patterns, triphasic spindle and alpha coma. Those have their own significance. We'll discuss it when if we have time to get into that. Slowing gives a lot of trouble to the newbies when you're starting out. Don't worry, it gives everybody trouble, but it's something you need to master. And we will talk about how to try to differentiate it as we read records at the education center. We will be starting this one-on-one reading shortly. And then we have the non-epileptiform activity, the benign patterns that are described in every textbook. So let's go to the next. I hope Dr. Tripathi has joined us from her meeting with the minister, but if not, this is a case that she's now managing for us from Delhi. And this is how EEG was recorded in a town which is close to Delhi. What you're seeing is this monomorphic rhythm. It is in all channels. Beautiful colors. You see all the different colors that are used to demonstrate different channels. This is page number 24. But if you looked at page number 42, page number 2, page number 4, or any combination of 2 and 4, it looks the same. Every page looks the same. There are a few of these electrode artifacts. I do not know what this is, but it is not what Dr. Tripathi found when she did the subsequent analysis and went on to do an SEEG, and Dr. Sarachandra did an ablation at that point. The patient has daily seizures. They tend to be focal, and there is brief arrest of activity. There is a stereotypic eye movement, and there's a hand movement that occurs with it, which led us clinically to think that this was right temporal or right frontal, in origin. Turned out to be insular. This is how the report came in the first EEG. And again, you make your own conclusion. If you see such a monomorphic discharge, they've done a great job at describing the conditions recording, but the basic activity, it's a mystery as how this has been described. There is no eye potential that was seen, and we are unable to identify these findings. So I'm not sure what to make of it, but we occasionally come across these types of recording. The course is designed so that you will avoid making these kind of errors. It also talks in the impression about interictal epileptomy. discharges at places. This is a very non-specific statement. Please avoid these statements. Try to be as focal and as committed as you can. And that's why you have the classification scheme. And lastly, this kind of thing, which you'll see in various MRI reports, for example, where they are giving clinical advice, we try to avoid that also in EEG. We do not like to give clinical advice. That is up to the referring doctor. There's one exception. I have started writing a line when you have a primary generalized epilepsy patient and there's irregular, say, generalized spike wave or rapid spike and wave suggesting GME. I do write a line that in these types of primary generalized epilepsy, it is best to avoid sodium channel drugs such as dilantin, carbamazepine, and you prefer broad spectrum anticonvulsants such as Keppra, because we're seeing so much misdiagnosis here in California and in Delhi. Okay, so please be aware of what not to do. So now that you've learned how to write a report, I'm going to go into how I would like you to give some degree of prognosis in the report to the referring doctor. This is a more difficult area and you need a lot of experience and you want to be careful what you say, but here are some easy rules. Let's look at this record. It has very prominent spike and wave. There's an abrupt onset and it is very regular. Regular means a 1-to-1 correlation between each spike and each slow wave. It's typical for classical absence. Focus on the word regular, focus on the number 3. Incidentally, in this, you will see this occipital rhythm here at about 3 Hz. This is OIRDA, O-I-R-D-A, occipital intermittent rhythmic delta activity. The opposite of FIRDA, frontal intermittent rhythmic delta activity, which we'll come to in a minute. So those of you who had the answer correct in the chat box, you can pat yourself. Again, in the report, please write. You want to recreate, you put in the words, the image that you see. So you make a clear comment on there is a abrupt onset, there is a spike followed by an aftercoming slow wave, which is high voltage. The spike is on the ascending limb of the slow wave. This is the descending limb. It is 3 Hz. It abruptly stops. These are the things that are telling you 1 year later when the patient reappears in the emergency room, you read the next record, this is what you were looking at the first time. Next, this is an example of a patient we recorded with a lot of these fast rhythms and then a slow wave. A lot of the fast rhythms and the slow wave are even greater as the patient goes deeper into sleep. You'll have to keep an eye at the time here, and you'll see our recordings are usually 1 hour. So we're about 25 minutes into it. And as you get deeper into the recording, there's more polyspike activity. So focus on the word poly. And that poly spike and wave, when you see it, indicates that the epilepsy is going to be more intractable. Again, it's still generalized epilepsy, but it's going to be more intractable. You're going to see this more in GME. And remember, GME, which is a short form for juvenile myoclonic epilepsy on chromosome 6, is more intractable. According to Dr. Jans, who first described it, his patients are still alive, and since he described in 1957, you do the calculation, they're all senior citizens now. He says most of them still have it. So there is a small chance of some remission there, but that is the exception. Let's not get into that. They are, for the most part, going to need lifelong treatment. As you look at the time here, the patient's deeper in sleep, more polyspikes, and then you see polyspike and wave. So try to record longer. Try to record for at least 1 hour. That's our standard in our lab. I know you have different times. Again, in the chat box, please write down what is the time duration that you record in your lab. All right, now we are going to go off the record, and I'm going to share with you what I use as the rule of three. If Rebecca's in, she will be smiling because we have discussed this many times. Rule of three is if you take the rhythm three from and bracket yourself from here to here, absence epilepsy follows a regular pattern and is at 3 hertz. When you go faster than 3, that is 4 to 5 hertz spike and wave, that's juvenile myoclonic epilepsy. You can have that with generalized tonic-clonic seizures, you can have it with absence, and so those who are splitters will say, it's juvenile absence or juvenile uh, myoclonic with generalized tonic-clonic seizure. It's all the same, but intractability increases as you move away from the number 3. Again, when you get slower from 3 and the rhythm, the spike and wave is at 2 or 2.5 hertz, that is called slow spike and wave. It's slow relative to something, right? Everything has a speed relative to, so it's slower to 3. So my rule of 3 is 3 is your center line, and anything slower than that is slow spike and wave, which is associated with atypical absence. For the technologists, when you take a history, you see slow spike and wave, please ask the patient about, do they stare? Do they jerk? Do they fall? Each of these is a different type of seizure. The staring is your absence, the falling is atonic, and the jerking is myoclonic. It will help the interpreting physician if you write that in the comment section or in your notes. And lastly, to add to the rule of 3, if you see polyspikes and then a slow wave, this is going to be an intractable patient. So you can mention that in the report. Once you're comfortable with this, then you can go ahead and make that leap. But be careful. And lastly, there's a small little rule of 6 that I have. And again, pointed this out to Rebecca, and she'll be smiling. The rule of 6 is that any rhythm you see that's at 6 hertz, just 6 hertz, the chances are that this is going to be benign. So think of rhythmic mid-temporal discharges. Think of wicked rhythms. If it's 6 hertz, look at it again before you call it as abnormal. All right, here are some simple methods you can use for improving quality. And most of them I have put down because I noticed that in the previous lecture, there was a voltage map that was suggested. It looks very pretty, and some programs may have it, some may not. You don't really need a lot of these new gadgets and gimmicks. I'm going to go back to paper EEG in just a minute and show you. You can get all the information you need with some basic rules. So if you just did the following, upgrade your monitor, go to 1920, not 1026. The pixelation will decrease. The postings that you have on WhatsApp, a lot of them are pixelated. You're taking screenshots. It's very difficult to read those, especially from a phone. So try to do a posting directly. I don't know how the technology is, but directly from the screen by doing a print screen and post it into WhatsApp. That will remove the pixelation. Then take out your 35 hertz muscle filter. It's there in a lot of recordings and some of those that were previously presented. That's going to clip your spike at 35 hertz and blunt it. Remove the notch filter. In Delhi, that'll be 50 hertz. Here, it'll be 60 hertz. But remove that because you want to open the window up to 70 hertz. You think of the recording just like you're listening to music. So I was told by a sound engineer when I was designing a speaker system for myself, and he said, your hearing is 20 to 20,000 hertz. And he was with me in Narayana. He had a company called Woodstock, and he said, if you put in a high frequency filter clipping at 10 hertz, you will lose the high tones. You know, the sound of a santoor, for example, is very high pitched. You will lose that. Similarly, the fidelity of the spike will decrease if you use the high frequency filter. Likewise, For the low frequency filter, most of us cannot hear below 50 hertz. But if you take the sound down to 20 hertz, you add a woofer to your speaker system, then you get better bass and you appreciate that, when the sound can be felt almost, you know what I mean, by increasing the low pass filter. So make sure that slowing is not clipped by going anything above 1 hertz. Then you increase the sampling rate. We'll come to that at the end because I have a special section for that. But you want a high sampling rate, otherwise you will be aliasing. And that is a basics of the Nyquist theorem. Those of you who read the theory behind it, you got to be at least 2 times the frequency of the maximum frequency that you are aliasing, you're recording. So let's say you're doing routine recording and the fastest frequencies are at 35 hertz, so you got to sample at 70 and above. But we normally try to record up to 100 hertz because sometimes it affects the recording, especially if you do intracranial recording. So you want a sampling rate of 200 hertz and upwards. Current amplifiers are way above that. Next, you take out all the color. A lot of your posts on the WhatsApp have color. The problem with color is that it directs your brain in one direction. Whatever way you are wired, whichever way your parietal lobe is, it affects the next thing, how to distinguish asymmetry. So in all my recordings, you will see only black. We are very boring, but we are black. You use the magnifying glass. The magnifying glass we used to say on paper recordings was the pencil. You draw a rectangle over the area of interest. Then all of you who are reading together, focus on that rectangle. Then you decide what you want to do with that portion. In the current digital situation, you use a virtual pencil. You make the montages easy on your brain. You use simple longitudinal bipolar montage initially, especially when you're doing long recordings. Our ambulatories are typically 100 hours. So you have a lot of epochs. You will be tired if you keep using referential during the initial phase. Yes, when you identify an abnormality, switch to referential. Then if you see an asymmetry, switch to alternating. You will see alternating montages used a lot in Europe. They are great for showing asymmetry, but much more difficult to analyze. Avoid the circular montages and avoid triangles, okay? And then lastly, what is the duration of your recording? So folks can each write your answer in the chat box. In the end, we'll see what you all arrive at. This summary is Rebecca rules. Oh, did I say Rebecca rules? No, it's Rebecca's rules. Okay, a question came up in the last presentation. How do you distinguish central spikes and vertex activity? So this problem has been there for a long time. We've had this for years. You can sometimes have a patient, particularly in the younger ones, where the K complexes are very spiky and high voltage, and you're wondering, is this a spike or not? Central spikes in general are very rare. I'll ask the panelists for their opinion, but I can only think of maybe 2 cases that I've had in all these years where we were convinced these were central spikes. Remember, there is nothing to record on the top of the head. There is no brain here. It's just there. What is there on the top of the head? It's nothing but the superior sagittal sinus. So you don't have a generator there to give you a nice spike. Instead, focus your efforts and your eyes on the temporal chain, the frontal areas, and then the occipital. That's the order in which you're going to see spikes, okay? Stay with that KISS principle. Keep it simple. I leave out the last word, principle. So there was a lot of description of how one person had pointed out, you can look at 6 deflections in a spike and wave, and you can decide whether it is a spike or it's not a spike. this is a way of splitting. We are from the group that likes to lump, to keep it simple, to keep it practical, and keep it fast, because the volumes are very high, as I'll show you. So in keeping with that, a spike is something you put your hand on and it hurts. A sharp wave is something you put your hand on, it hurts, but not as much. You get the feeling? You can do this exercise virtually, and I assure you it will work every time. Next, we'll go to the topic of overreading. And this was alluded to in the last meeting, but it is a big problem. It is the reason why we're doing this course, the reason why we are building the Neurology Education Center, why we have a whole section devoted to just teaching EEG. So I'm going to share with you some observations. And the first, if you go up here, observation, I looked at the misdiagnosis of epilepsy and EEG reading with Dr. Sabharwal, and we were discussing. Dr. Sabharwal, by the way, is my colleague from Gangaram Hospital, and we've been reading EEGs for a long time. We're looking at, is there any data that shows what is the misdiagnosis rate? And in the mid-2000s, this is all I could find. It's taken from the lay press. It is from the BBC's website. And they estimated that 1 in 4 cases, about a quarter of the patients in the United Kingdom, were being misdiagnosed. Many factors for that, but if you use this yardstick in India, the number is going to be huge. So I am going to summarize some of the things that we observed both in California and in the population that came to us in Gangaram Hospital that led to the misdiagnosis both on EEG and in epilepsy. And believe me, this problem is there here in California in the Central Valley. We are in a rural area, relatively speaking. We're between Los Angeles and San Francisco. So academic centers are far away. Those that are closest to us are UCSF, with whom I work. But in the area, EEGs are done by individuals who are not necessarily familiar with EEG reading. So one of the things that we have noted is the inadequate training, which has been highlighted below. Interpreting with a pattern recognition approach, that is, you open a textbook and you look at a pattern there, look at what you have on your screen and try to match it. Then because of your level of training, you would tend to overcall certain EEG abnormalities. The difference between adult and pediatric training is huge, and we will address that in our course. We will be coming again in October to do an in-person course, and this will be based at Anjali Center and at Gangaram Hospital and GB Pant Hospital, where Dr. Mendiratha was. Again, we will go on with the rest of the observations. There's overemphasis on EEG findings in diagnosing epilepsy. The classic example is you have a child who is a sibling of someone with benign Rolandic epilepsy, and for some reason that sibling has an EEG and shows the traits, the findings of on EEG of, let's say, centrotemporal spikes occurring independently, and there is increase in these spikes in sleep. Now, this may just be an electrographic finding. There is no clinical history of a seizure. This is just a genetic marker for that particular epilepsy, and that patient gets treated. That would be an unnecessary treatment. Then the previous discussion, they're looking for abnormality approaches because we are doing an EEG to find something. You try to confirm it, you try to make that diagnosis, because it's the dog chasing his tail, self-fulfilling prophecy that leads to it. Okay, we'll discuss this further in our course. Technical limitations are that when the recordings are with a lot of movement, there's abnormalities, there's a tendency to call it abnormal. Benign patterns can be called abnormal. We will address that also in the section on the benign patterns. You have already discussed that earlier. And then lastly, the EEG that is provided to patients for a second observer to review may be incomplete and you may not have the entire sample. So you will miss out on some of the abnormalities and that will lead to a incorrect diagnosis. I'm going to now switch to the incorrect diagnosis issue or overdiagnosis issue here in the US. So here is a survey that I took in the pre-COVID times of 2019 on the AN website. And the AN had asked, if you're reading EEGs, take the survey and see how you do compared to your peers. So first question is how often you read EEGs? And the second was, have you had specialized EEG training after residency like you did in EEG fellowship? And then what is your volume of reading EEGs? So pay attention to the top. In this section here, almost 31 plus 78, the majority of peers who were reading EEGs were reading them on less than a weekly basis. That's not enough. The daily readers were 3% or less. That would be mostly in academic centers where a person is designated, okay, you're going to read all the EEGs, we're going to be in the clinic seeing patients. Then those who've had specialized training here in the US, about 40% have just got the 3 months of training. Typically, it's 3 months of training during a EEG rotation when you are in your neurology training program. Another 20% said, yeah, we had some additional training. Another 20% said, yeah, we got some epilepsy fellowship training, but epilepsy fellowship is different from clinical neurophysiology, as you all know, because some epilepsy programs only deal with the epilepsy treatment in the clinic and medically intractable or drug-resistant epilepsy, which is a huge thing. So you have only a small percentage that would be trained similar to the course that you are taking. Looking at volume, the majority, 47, if you add these two, read less than 20 EEGs a month, and at least half less than 10 in a month. There's only 15% that's reading more than 2 EEGs a day. You need a much higher volume in order to read and to get proficient. So they rated me in this green section. You see this? You want to stay in this green section if you want to get better with EEG. The Coca-Cola company wants you to drink more Coke, and we want you to read more EEG. The more you read, the better you'll get. Okay, we have addressed the issue of intraductal abnormalities. We will switch for a moment to reading ictal rhythms. They're slightly different. In the practice that you will have, for the most part, it will be all in the clinic. You will be reading office-based or clinic-based EEGs. You may from time to time come across ictal rhythms. Leaving aside the 3 Hz spike wave, which is a classic ictal rhythm in children, these rules are for focal epilepsy. You look for a change in the rhythm and in the voltage, and then you look for fast activity such as beta. There was a great example of this in the previous EEG shown by last presenter. That beta indicates there's neocortical onset. Then you look for that beta in or attenuation activity evoluting. Evolution means that there's increase and decrease in the frequency. There's increase or widening of the field of the activity. I'll show an example of that. A change in the frequency of faster rhythms appearing and then slow waves coming in, and then a spike and wave configuration. This is your typical generalized tonic-clonic seizure, where you have a fast frequency, a fast rhythm, then slow rhythms that are intermixed as the thalamus kicks in to inhibit the discharge, and you get a spike and wave. And after that, you get slowing. The entire sequence leads you to conclude this is a generalized tonic-clonic seizure. This is critical for diagnosing non-epileptic events and epileptic events. You saw that presentation earlier by a doctor from Kuala Lumpur. He was very good in showing us the Chinese drummer. That was a very difficult case in which this sequence of rhythm, if present, would help in diagnosing. You always look at the post-ictal period. Number 4, this focal slowing. You keep looking for focal slowing. It will appear in a majority of patients if you look carefully. Don't disregard that as, oh, just artifact. And then, of course, you look at the non-cephalic channels for increase in heart rate, change in heart rate, arrhythmia. And we talked about how important that is because even the cybernetics company has recognized this and integrated it as part of the newer vagal nerve stimulators. And then hippocampal seizures, you may have a theta or alpha frequencies, a little unusual. You're more likely to capture these with, if you're doing depth recordings. Delta frequency was described well as a slowing over the temporal region. We call it TERDA, or temporal intermittent rhythmic delta. It is similar to ORDA, which we see in the back of the head. This is over the temporal part of the head. In the front of the head, when you see frontal intermittent rhythmic delta, we call it FIRDA, F-I-R-D-A. So this TERDA, if seen over the temporal region, as in the example of the last presenter, is a very good marker for epilepsy. All right, here's a ictal example that we are going to get into. A 23-year-old, he's had at least 6 generalized seizures, all are in sleep. He went to different community hospitals around us, had multiple EEGs, all were normal. So we were wondering whether this is real or not. This is the recording in my office. It's ambulatory. It is a little bit older, okay, but it is at 1 o'clock in the morning, okay? Not much activity here. I'll let you just look at it first, okay? And we'll come back to analyze it. This is the next 10 seconds. First 10 seconds. Ignore the EKG channel, which is blue, because he's either laid out the electrode or it's dislodged. Forget the red markers. This is your spike and seizure detection program. Ignore that. And this is a detection by the spike and seizure detection program. Yes, it did pick it up at this time, but for the most part, ignore it. Just look at the scalp recording. All right, now let's analyze it. So in the first second, stay with the first second. It's a symmetric background. There's not much activity. There's no eye blinks. In the second second also, there's not much activity, but if you look carefully, there is something appearing here, which is very low voltage, but is a rhythm. And if you look at that further, it becomes a little high in voltage. And then you see these sawtooth waves, they reach almost 6 hertz. They are high in voltage over the left hemisphere. Remember, same longitudinal bipolar, left over right. It's higher over the left hemisphere. It starts here, 8 seconds of it, go to the next epoch. It continues, it's much better over the in field and in configuration on the left side. And then it stops all of a sudden. The background flattens for a second. The patient wakes up and you see an organized background right here, okay, with alpha. So this is about 10 or 11 seconds of an electrographic seizure arising from the left temporal region. The way I would write the report, and please compare with what you have mentally thought this out, is there is abrupt appearance of a low voltage rhythm over the left temporal area. This becomes rapidly at 5 to 6 hertz. It's sawtooth, lasts for 10 seconds. The voltage and field increase, extending over the left temporal area up to F7. So you can see the field is up to F7 at least. Not much of a field here in FP1. Remember, it's bipolar, so we have to make some give it some laxity for that fact. What you don't see much activity going on on the right side, except that this may be a projection that is seen on the right side at the same frequency. And then there's abrupt termination of this rhythm. The patient has return of the background rhythm. Then there is an eye closure followed by a waking background with an occipital rhythm of 9.510 Hertz, whatever you like to describe. There is some muscle artifact. So you've described the entire seizure electrographically. And now if there's another seizure that occurs later and you record it again, you can compare the two. Remember, create a picture of what you see visually in your parietal lobe, in words, and on paper for the next observer. All right. This patient went on to have an MRI negative epilepsy, and the PET scan showed hypermetabolites supporting this. He worked in the casino. He decided he didn't want to do any further workup. Okay, to answer your question about how do you differentiate the vertex activity and how do you differentiate spikes occurring from the vertex region? Well, go to this book that Dr. Goldenson has written. It's called EEG Interpretation, Problems of Overreading and Underreading. For those of you who have ever looked at it, it's now out of print. We have a few copies which were generously donated by EEG technologists from various labs, particularly Janet Kigo from Chicago. It's basically a full-size image of paper EEG. Those of you who are trained in paper EEG will remember these were the large sheets we put on wooden angled boards, and we would turn the pages and read them. It is the exact replication of paper. And these were collected by Ruth at Columbia University when Eli was at Columbia. So he put all of them together. This is one example I pulled out of it, and I am trying to show you how polyspikes and vertex activity are intermixed here. This waveform here is your vertex activity. This is spindle activity, and this activity here, much faster in frequency preceding it, seen here again, is the polyspike. And that's what he's trying to describe. There is, in the entire book, only one page devoted to central spike. And that spike is described in a child. Most of the time, if you do see a central spike, it will be a child, often with spastic diplegia or a injury that affects both legs. So therefore, you get a parasagittal spike, but very rare. Here's somebody we recorded about 2 weeks
Dr.
ago.
Suri, we have reached gone. Yeah, Dr. Suri,
Yes.
Dr. Rawat here.
Yes.
We have gone beyond 8 p.m., so we need to conclude it, sir.
All right. So I will conclude now by giving you, I have a few more slides, but I'll conclude by saying that, yes, you can get polyspike and wave. And I had some examples to
Yeah, you
show
can
you.
finish a few more slides, sir, as soon as
Okay.
possible. Yeah.
Okay. So I thought this was be helpful to you that in this recording last month, you can see the polyspike and wave, and you can see focal spikes occurring frontally. You see these examples? These focal spikes can occur as part of the same record in these patients. Here's another. If you just saw this page, you would call this as a focal spike, but it's just a fragment of that spike and wave. And this was described by Dr. O'Brien in 1959. It's as old as the hills. O'Brien and Goldenson had described it in 3 Hertz spike wave. So you can get focal spikes in there. Please don't write in your impression it's a focal record. You have to globally put the whole thing together and say, this is a generalized epilepsy. Again, these are focal polyspikes. This is the spindle activity seen 3 seconds before. Same patient that we recorded last month. Okay, so to make this, to take this to the next level, you will see patients who have had, say, hypsarrhythmia in childhood. And I give you the example of my own family where I have an EEG in a family member who was recorded in Brooklyn in the 70s. That EEG was reported as high voltage. There was only a few lines. Later on had focal seizures. As the patient grows up, those hypsarrhythmic patients go to Lennox-Gastaut type of a picture, then multifocal spikes, and then it can evolve into focal seizures. And this family member went on to have epilepsy surgery and is now controlled, although the epilepsy surgery had its own complications, but is controlled on one medication. So again, you try to telescope all EEGs together. Suppose you had a stack of 3 EEGs before, now you're doing the 4th EEGs, you try to put the picture together, and in the impression, you would say that this is a picture of secondary generalized epilepsy in a patient who had hypsarrhythmia in the past, who then evolved, then developed focal epilepsy, and what we're looking at now is etc., whatever you want to describe. So I went on to describe a different patient, not what you're seeing on the screen, but I'm trying to cover a lot of ground here. The last point is about the sampling rates. This is all the EEGs you've seen are recorded in this system. Sampling rate here you'll see is about 1200. We are moving to this system. Sampling rate here is going to be 1 million, which is 1 megahertz. In this comparison here, on line 2, you look at the sampling rate. This is 1 million. In another piece of equipment that we're looking at, sampling rates up to 100 to 512. The higher the sampling rate, the more data points you have on the spike. So you will get a sharper spike and better recording with the higher sampling rate. So ask your supplier or whoever is giving you these the equipment for the spec sheet. Don't believe what they say. Ask them for the spec sheet. The second factor that affects the sampling rate is the storage rate. That's line number 3. So your storage rate here on the equipment that we're going to install this month is going to be 2000 hertz. And for the other equipment that we're looking at is 200 hertz. This is the more data points you record or sample and you can display, the better the resolution will be. So it doesn't matter even if your sampling rate is high. If you don't store enough, you're not going to show it. So please look at the storage rate. And then lastly, look at this, which is the AD converter. That is, you have an analog signal that is being recorded. It's just a pen that's moving up and down. And that pen deflection has to be turned into a digital image. So basically, this is, if we have time, we'll go into it, but I will stop at this point that just to leave you with the statement that the AD converter rate should be higher to faithfully represent the signal with high fidelity. Okay, I am open to questions. And I request Dr. Rawat and Medhirata to...
Yeah, thank you very much, Dr. Suri, for enlightening a very good talk on how to do and what fallacies which we make while reporting. So I think we have gone a little beyond time, but I will just take 1 or 2 questions. One of them is that can FIRDA be seen in children?
I'm sorry, that cut out. What can be seen in children?
Can FIRDA, frontal
FIRDA.
intermittent rhythmic,
Okay.
be seen in
That's
children?
a great question. So it is not likely you will see FIRDA. I have never seen it. You see the equivalent in children, which is ORDA, OIRDA, occipital intermittent rhythmic delta, because children express themselves through the back of the head. Adults express themselves through the front of the head. You remember that rule that Arya had provided? She had shown you that how children are not miniature adults. They are different. They behave differently.
So there's one more question. I think the only was that what is the difference between inter-discharge fragmentation and intra-discharge fragmentation? And what is the significance?
I think I heard intra-discharge fragmentation.
Inter-discharge and intra-discharge. What is fragmentation? What is the difference between the two? And what's the significance?
I'm not sure I understand the question.
Yeah, even I do not know what they are.
Yeah, so
They are asking for inter-discharge fragmentation.
inter-discharge fragmentation. Well, all I can say is that, between discharges, if you're talking about a burst suppression record, you would see between the bursts, there will be flattening of the record relative to the bursts. Is that what the questioner is asking? When within the burst, there may be fragmentation. Is that the question?
I think so. Within the burst also there may be a fragmentation.
Okay.
Where the burst is little longer of 1 or 2 seconds, and then you may have a fragmentation in between, but I'm also not sure what she's trying to say. So
Sure.
with that, I think we come to the end of the questions. I think there are no more questions. I think everybody's asking for the videos. And yeah, there's one more question, last one. I think why slip spindles generate from posterior mainly? Which part of the brain they generated? Why it is generated from posteriorly?
Okay. Spindle activity you will typically see in the frontocentral region. Normal spindle activity
Yeah,
appears.
not posteriorly.
Yes. So you look for it in a longitudinal bipolar, you focus your eyes on F3C3, F4C4, look in those areas. You will see it appearing, yes, you'll see it after the neonatal period, which is the first 30 days of life. You'll start seeing them appearing both sides of the brain. And we look for symmetry. Then you look for whether they are synchronous. So symmetry is whether you have it on the left and the right. Synchronous is whether they're both timed at the same time. And by 6 months of age, they should all be synchronous. And then you look for vertex activity, which is vertex waves that join it. That gives you the complete picture of sleep. You don't see them
So
at the
thank
back
you,
of the
Dr.
head.
Suri. I think there are no further questions. We can come to an end of the session. Thanks a lot for your talk, and thanks to all the participants. And I'm sure we'll be sending the videos. There are lots of requests of sending the link for the videos. And I'm sure the admin people will do the needful. Thank you very much.
Thank you.
Thank you.